and welcome to tonight's free virtual webinar where we'll be discussing risk factors, genetic testing, surveillance, and research related to pancreatic cancer. My name is Annie Dalton Flores, and I'm the Executive Director of Sky Foundation. I've been part of this organization for about 8 years, and I had the honor of working very closely with our founder, Sheila Sky Castleman. Sheila's passion for supporting patients and advancing research continues to guide everything we do, including events like this one. Tonight's webinar was conceptualized by Samantha Castleman, who serves as our board of directors and is also our liaison to the Scientific Advisory Committee. This mission is incredibly personal to her, as Sheila was her grandmother. Samantha is currently pursuing studies in genetics with a focus of pancreatic cancer, and she'll be leading the slides for tonight's program and the Q&A portion later this evening. A couple housekeeping notes before we begin. Everyone is muted. Your video is off for this session. This ensures you can focus fully on the presentation without any distractions. We encourage you to submit questions throughout the program. There will be a little Q&A button also at the top of your screen next to that chat button. Feel free to submit any questions throughout the program there, and we will address it at the end. And finally, tonight's presentation is being recorded. We'll send the video out to all registered participants, post it on our social media and our website so that you can revisit this information and share it with others who might benefit. Now, I have the honor of introducing our experts from Michigan Medicine who will be guiding us tonight through our topics. Andrea Murad, MS, CGC, Clinical Assistant Professor and Lead Genetic Counselor. Andrea specializes in hereditary cancer syndromes and is active in national leadership roles for genetic counseling practice guidelines. Dr. Elena Stoffel, gastroenterologist and clinical professor, director of the Cancer Genetics Clinic at Michigan Medicine. Dr. Stoffel is a nationally recognized leader in cancer genetics and early detection with a focus on hereditary cancer risk and health equity. And lastly, we have Sarah Volk, Senior Clinical Research Coordinator in Gastroenterology and Hepatology. Sarah leads research coordination for major studies focused on pancreatic cancer screening and early detection, including the nation's 2 largest studies looking at pancreatic cancer risk. With that, let's get started. I'll begin to hand it over to Andrea Murad, who will walk us through the risk factors and the role of genetic testing in identifying pancreatic cancer risk. Oh, Andrea, it looks like you're muted. There you go.
Thanks, Annie. Good evening, everyone. Thank you so much for having me here. I'm happy to be here to speak with you all about genetic or inherited risk factors for pancreatic cancer and who might be at risk. So when we think about risk factor for cancer and causes of cancer, specifically pancreatic cancer, what we know is that the majority of pancreatic cancers that we see are what we call sporadic, meaning that they happen potentially by chance. We might not know the reason why somebody developed the pancreatic cancer that they have. Certainly, we know that there are risk factors that can increase a person's risk for developing pancreatic cancer. Those could include things like having a condition called chronic pancreatitis, simply getting older. Smoking is also a big risk factor for pancreatic cancer. However, we do know that roughly about 10% of the pancreatic cancers that we see, somebody will have developed that because they have a genetic or an inherited predisposition. So they were more susceptible or more predisposed to develop pancreatic cancer. And that genetic or inherited predisposition is due to an identifiable genetic change. So a change in a cancer susceptibility gene. There is an additional group that we consider or we call familial. And really the biggest difference between the genetic or inherited group and the familial group is in the familial group, we do actually see more pancreatic cancer than what we would expect to see by chance in those families. However, we have not yet been able to identify a genetic cause of the cancer that we're seeing in that family. So what do we mean when we say hereditary cancer? So when we think about how cancer develops, in sporadic cancers, people are born with no genetic changes in their cells that we expect their genes to be working typically. But as we age, we can have changes in those cells that occur after birth. With sporadic cancers, because those individuals develop those changes as they age, we tend to see later ages of onset with those cancers, but that's not always the case. With hereditary cancer, what we mean is that individuals are born with a genetic change in every single cell of their body. So kind of making them one step closer to developing that cancer. So they are born with a genetic change in every single cell of their body, but then also there are genetic changes that happen after birth as they age. Generally speaking, oftentimes with inherited cancers, we tend to see people developing those cancers at younger ages than the average. And why could genetic testing be important for your care? So one of the reasons that genetic testing is important is that oftentimes it can help to clarify an individual's risk for developing pancreatic cancer. Because many of these genes also confer risk for other cancers besides pancreas cancer, it could also inform your personal risk to develop other cancers. And as I'm sure you're all aware, genetic changes can be passed down in our family. So identifying a genetic change, if there is one in the family that is associated with risk for cancer, can be informative for other family members. Sometimes for individuals too, genetic testing can really provide a lot of reassurance. If there's a known genetic variant in the family and somebody does testing and doesn't have it, then their risk is much closer to the general population. So therefore, they're not at an increased risk. Another way that genetic testing is super important is that it can help identify those individuals who are at higher risk and who would benefit from screening for early detection. In some cases, depending on what types of cancer we're talking about, there might also be options for individuals to do prophylactic or risk-reducing surgeries, or maybe even some medication management to help reduce the risk for cancer. For those people who have been diagnosed with pancreatic cancer themselves, so they've already developed a cancer, genetic testing still could be important because it could help impact the treatment that their oncologist or their care team is choosing for them. So when we talk about the different genetic genes or genetic changes that we know to be associated with risk for pancreatic cancer, there's a handful of ones that we've identified, genes that we've identified over the years. In the general population, so in an average person who does not have a first-degree relative with pancreatic cancer, their risk to develop pancreatic cancer in their lifetime is estimated to be somewhere around 1 to 2%. As you can see, if somebody's identified to have what we call a pathogenic variant or a mutation in one of these cancer susceptibility genes, that risk for pancreatic cancer can be increased quite a bit above the general population, depending on what we're talking about. If you look at this graph here or this chart here, you can see some of the genes that maybe some people might be more familiar with, maybe the BRCA1 and 2 genes, often called the BRCA genes. Those genes are ones that we know to be associated with inherited risk for breast and ovarian cancer, but also confer risk for pancreatic cancer, somewhere between 5, maybe as high as 10%. There's another more common, and when I say common, I just mean common in the world of genetics, probably not in the world as a whole. Genetic conditions is a condition called Lynch syndrome that you'll see mentioned there. Lynch syndrome also is most often associated with risk for colorectal and uterine cancers, so certainly identifying that could change screening for more areas than just the pancreas. Looking at some of those genes on the right side of the chart that have maybe a slightly higher risk than the ones we've been talking about are a couple more rare genetic conditions. One has had multiple different names over the years, but it's associated with the CDKN2A gene. It was previously called familial atypical multiple myelin melanoma. Some people call it hereditary melanoma. As you can see, risks for pancreatic cancer are quite high with that, but individuals also carry a risk to develop melanoma skin cancers. And then a particularly rare genetic condition called Peutz-Jeghers, which is associated with the STK11 gene. One important thing to note on this chart is that that gene on the end, that PRSS1 gene, that particular gene is associated with increased risk to develop chronic pancreatitis. Simply having a genetic change in that gene by itself does not actually increase your risk to develop pancreatic cancer. It's in fact the chronic pancreatitis that would increase your risk. So it's more the chronic pancreatitis rather than the genetic variant alone that would be increasing risk. But all of these different genetic conditions would potentially, if somebody were identified with them, would involve somebody beginning pancreatic cancer surveillance when they might not otherwise be doing that. So who should consider genetic testing? Current recommendations say that anybody who's been diagnosed with pancreatic cancer should consider undergoing a genetic evaluation of their own. If that individual is unable to undergo a genetic evaluation, then recommendations say that their children, siblings, parents should consider undergoing a genetic evaluation. Additionally, anybody who has multiple relatives, close relatives with pancreatic cancer should consider. And then, of course, anybody who has a known genetic variation in the family should consider undergoing testing. As far as how often or if people need to repeat genetic testing, our knowledge does not change super fast in the world of genetics, but if anybody's had genetic testing 10 or more years ago, it certainly would be useful to consider meeting with a genetic counselor again, because our knowledge, or at least our technology, may have advanced over the years. And so how does somebody see a genetic counselor or get a genetic test done? I would say in my experience, most individuals, primary care physicians or providers aren't generally able to order the genetic testing, so they would generally refer you out to a genetic counselor or a genetics clinic. You can ask your primary care. If you see a gastroenterologist, ask them. They can place referrals over to you to a genetics clinic. The number on the screen shows where you could call for our clinic at Michigan Medicine. We don't generally require people to have referrals. I will say that it's usually more beneficial to you to have one because it oftentimes helps with insurance coverage, but it's not required. And for those of you who maybe don't live near Michigan Medicine or in the state of Michigan, if there's anybody from outside of Michigan attending today, you can go to this website. The National Society of Genetic Counselors has a wonderful tool that can help you find a genetic counselor in your area. You simply put in your zip code and you pick cancer as the specialty, and you'll get a list of names and providers that you can call to get scheduled. So now I'm going to pass it back to Annie.
Thank you so much, Andrea. That's such valuable information that we should all know. So thank you so much for sharing all that. Next is Dr. Elena Stoffel to speak about genetic surveillance, including who it's for, what it looks like, and why it's such a powerful tool in early detection.
Thank you so much, Annie, and thanks, Andrea, for such a great introduction to the genetics of pancreatic cancer. Sammy, could I have the next slide, please? So when we're talking about cancer screenings for pancreatic cancer and other cancers, we really rely on having data that demonstrates that catching something early makes a difference. And in the case of pancreatic cancer, we know very clearly that finding pancreatic cancer at the very earliest stages can make a tremendous difference in clinical outcomes and in survival. This curve here shows really starkly how finding pancreatic cancers at stage 1A or 1B can be associated with tremendous improvements in survival as compared to pancreatic cancers that are even caught at stage 2 or 3, where the 5-year survival is under 20%. And I think that in the past 20 years, when there have been a number of different advances in many different cancer types, pancreatic cancer has unfortunately lagged behind because we our drugs don't tend to work as well to treat pancreatic cancers, but also we haven't had a good strategy to be able to find pancreatic cancers before they develop. And I think what this graph shows you is that it's the people whose pancreatic cancers were found almost by chance, based on perhaps an imaging study or or an X-ray test that was done for a different reason, that just happened to find an early stage pancreatic cancer, which would be amenable to surgical resection. That's the point at which we can make the biggest difference in terms of survival. So what I was charged to talk to you about today is how do we find pancreatic cancers at the earliest stages? And basically at this point, pancreatic cancer screening consists primarily of imaging studies. And those imaging studies include MRI of the pancreas, a particular test called MRCP, and endoscopic ultrasound, which is an endoscopy test that uses a special type of endoscope that has an ultrasound probe on the end of it that can look at the pancreas from the inside. The reason why MRI and endoscopic ultrasound are the tests of choice is because we actually have several decades of data that have shown us that MRI and endoscopic ultrasound find very early lesions in the pancreas, and they actually see these lesions better than CT scans. Interestingly, MRIs see cystic lesions a little bit better, and endoscopic ultrasounds tend to see solid things a little bit better. So even in studies that have used one versus the other, the conclusions have been that using both of these tests, alternating one year, alternating with the other one the next year, so that you have one imaging test each year, that strategy seems to be better than using either one of these tests alone. Now, a question that always comes up is, what about blood tests? And at this point, there aren't any FDA-approved blood tests that are better than imaging at detecting pancreatic cancer. I think that we often, and in the research space, we are working to see how combinations of blood tests with imaging may do better than either one of those alone. And for many folks who are engaging in pancreatic cancer screening through imaging tests, we look at other blood markers as well to see if these add any extra information. Blood tests that are available include screening for diabetes with hemoglobin A1C, which is a test that one could argue everyone should have because early detection of diabetes is important. And there's some data to suggest that development of adult onset diabetes may be a risk factor for pancreatic cancer. Although it's important to point out that there are a lot more people out there with diabetes than with pancreatic cancer, and certainly not everyone with diabetes will develop pancreas cancer. But hemoglobin A1C is one of the markers that we like to follow when we're following the pancreas. In addition, there are a few blood tests that have been looked at, and one blood test that's commercially available right now that looks at various different biomarkers to try to detect pancreatic cancer early. However, it's important to point out that at this point, we don't really have a test that's better than the imaging with MRI and endoscopic ultrasound. So the goals for imaging in the surveillance of pancreatic cancer is really in terms of early detection. And as I mentioned before, those tests, that curve that shows us that early stage pancreatic cancers have better survival, our goal is to actually be able to detect high-risk lesions in the pancreas even before they become cancers, because unfortunately pancreatic cancers can spread even at early stages. And in terms of preventing pancreatic cancer, our goal is to be able to find suspicious lesions in the pancreas and hopefully be able to treat them either through surgical resection or possibly through other interventions on these cysts. Now, the challenge is that cysts in the pancreas are very common. And for many patients who are undergoing pancreatic cancer screening with us, many patients will have cysts, but being able to tell what cyst is suspicious for being a high-risk lesion versus what cyst is just a common innocent bystander cyst really requires a detailed examination that is done by a multidisciplinary team that includes radiologists, gastrointestinal endoscopists, and often surgeons to be able to look at the characteristics of the cyst and decide whether this is something worrisome or not. And this is one of the reasons why pancreatic cancer screening in general is best done in centers that have the expertise to do this, is because pancreatic cysts are common, and one of the potential harms of pancreatic cancer screening would be subjecting someone to a dangerous operation for a cyst that turns out not to be a high-risk lesion. So I think that this is one of the reasons why in all of the expert guidelines that have come out lately, talking about pancreatic cancer screening, the caveat is that this really should be done at a center that has the multidisciplinary expertise to be able to characterize the cysts and other lesions of the pancreas. Next slide. So who should get pancreatic cancer screening? And I think that this is the really important point, because if you had it's 20 years ago, we were having arguments with insurance companies to try to advocate for pancreatic cancer screening for patients at increased risk. And the answer we were getting back from insurance companies were that there are no data to support that pancreatic cancer screening changes outcomes. Well, we're in a very different place today, because in the past 20 years, groups like ours at University of Michigan, as well as other centers from throughout the United States and the world, have been conducting pancreatic cancer screening on certain groups of high-risk individuals. And so who qualifies as high risk? Well, the based on the outcomes of screening in several high-risk populations, recent guidelines have suggested that high risk means someone whose lifetime risk for pancreatic cancer is 5% or greater. And it's important to point out that having one relative with pancreas cancer does not reach that high risk threshold of 5% lifetime risk. But the folks who do reach that 5% threshold, 5% lifetime risk threshold, are individuals who have particular genetic alterations, like Andrea was talking about, all those genes that she was talking about, including BRCA1, BRCA2, the familial pancreatic cancer multiple myeloma gene, if you have Lynch syndrome with a family history of pancreatic cancer, if you have a pathogenic variant in the ATM gene, or if you have a family history that includes 2 or more close relatives with pancreatic cancer, or 3 or more relatives in the family. So that is the main those are the main criteria for who qualifies for pancreatic cancer screening in this day and age. And as I mentioned previously, the reason why we're now able to get this pancreatic cancer screening covered by most insurance companies is because we've shown that that pancreatic cancers that are detected through screening have a much better survival than pancreatic cancers that just present with symptoms. And certainly here on the slide is the really striking difference between the median survival of screen-detected pancreatic cancer of being, 9.8 years as compared to less than 2 years for individuals who presented with symptoms. So this is what allowed us to convince insurers that pancreatic cancer screening is worth doing for individuals who meet those high-risk criteria, as I described previously. Next slide. So the National Comprehensive Cancer Network, the NCCN, makes guideline recommendations that tend to be adopted by many insurers. And so this is just their table for who meets criteria for pancreatic cancer screening. And again, the ages at which we start screening in general at age 50 or 10 years younger than the earliest pancreatic cancer diagnosed in the family, except for a couple of genes in which we start earlier around age 35 or 40 for the individuals at risk for Peutz-Jeghers and with the familial melanoma pancreatic cancer gene change, CDKN2A. Next slide. So how to talk to your healthcare team about surveillance or talk about how do you get pancreatic cancer screening. So I think it's really important when you meet with your healthcare professionals, they're going to ask about your family history and about your personal history. And I think that talking about your family history of cancer is always important. And certainly if you have a relative with pancreatic cancer, it's important to talk to your healthcare professional about that. But in general, unless there is a one of the gene changes that we described previously, having only one relative with pancreatic cancer does not get into that high risk criteria. But if you have 2 or more close relatives with pancreatic cancer or 3 or more in the family, or if you carry one of those gene changes associated with pancreatic cancer risk, that meets criteria for pancreas cancer screening. And so your healthcare professional should be able to refer you to a center near you that has expertise in pancreatic cancer screening. As I mentioned, Michigan Medicine does have a multidisciplinary team that we take care of a lot of families at risk for pancreatic cancer. And certainly we participate in a number of research studies, which Sarah will talk to you a little bit about, that continue to collect data on outcomes of pancreatic cancer screening in high-risk individuals. And we're also involved in some of the studies that are looking for blood biomarkers that may help us do a better job at identifying high-risk lesions earlier in order to make them treatable and curable. So thank you so much. And I think that might be my last slide. All right. Thanks so much, and I look forward to the Q&A.
Thank you, Dr. Stoffel. Again, very important information, and we're grateful to have you here tonight. Next, I'd like to introduce Sarah Volk, who will give us a behind-the-scenes look at clinical research taking place in the pancreatic cancer space and the vital role it plays in advancing early detection efforts.
Thanks so much, Annie. Thanks so much for inviting me to be here and representing our research. And as mentioned, I manage clinical trials in the Division of Gastroenterology and Hepatology at the University of Michigan. And I work with our amazing interventional endoscopists who perform the endoscopic ultrasounds for the pancreatic cancer screening. And our interventional endoscopy research program, in addition to early detection of pancreatic cancer, we actively conduct and enroll patients in clinical research trials involving pancreatic and biliary disorders, patients with pancreatic cysts, pancreatitis, and advanced imaging modalities. Next slide, please, Sammy. Thanks. So we currently have 2 observational pancreatic cancer screening studies at the University of Michigan, and I'll describe each in more detail on the coming slides. But in general, both of these studies are currently enrolling patients and families who have a family history of pancreatic cancer and or a genetic mutation associated with a higher risk of pancreatic cancer. And our enrolled patients undergo the annual surveillance that you heard Dr. Stoffel talk about, the annual alternating of MRI of the pancreas and endoscopic ultrasound of the pancreas. And that surveillance is done as part of standard of care, meaning the studies unfortunately do not cover the screening. They are billed through insurance. Next slide, please. So the first study is the Cancer of the Pancreas Screening Study, or CAPS for short. CAPS is a multi-center study, and U of M is one of 9 US sites, and the coordinating center for CAPS is Johns Hopkins. And this is an NIH-funded trial. And we're currently enrolling at Michigan Medicine patients and families. And the goal of the CAP study is to determine if high-risk individuals, if we can determine if they have pancreatic cancer before they show any signs or symptoms of the disease. And we determine this through those annual surveillance imaging, the MRI of the pancreas and endoscopic ultrasound. And we're hoping to develop better tests and tools for the diagnosis of pancreatic cancer and other abnormalities that could lead to pancreatic cancer later on. And our second study is PRECEDE, and that stands for Pancreatic Cancer Early Detection Consortium. And this is another multi-center study. PRECEDE, U of M, is one of 57 international sites enrolling for PRECEDE, and the coordinating center is the Arbor Research Collaborative for Health. And PRECEDE is funded through the PRECEDE Foundation. And again, at U of M, we're currently enrolling patients and families. And the main goal of PRECEDE is to develop and create a large resource to help researchers worldwide study the early detection and prevention of pancreatic cancer. So what is involved for our patients who are enrolled? The first thing that happens is our study team will sit down with you for our eligible patients who are interested, and we will go over the informed consent documents for both studies. And providing informed consent means that you're allowing our study team access to your medical record and your annual pancreas screening for at least 10 years. And while you're enrolled with the study, we may ask for additional information about your medical history and your family's medical history in regards to any cancer diagnoses. And while you're enrolled in our studies, at certain visits, we may ask for blood samples. And a perk of being enrolled in the studies is that we can easily assist with keeping your annual screening up to date. We have an extra set of eyes on your screening to ensure that you stay up to date, because we are very aware of how important it is to stay up to date. Meaning, if you need us to be a liaison to contact any of your providers, if you need assistance scheduling an MRI or endoscopic ultrasound, we're always happy to assist. We get to know our patients very well who are enrolled. So with that, I will hand the presentation back over to Sammy.
Thank you. Thank you, everyone. So 2 big thank yous to go around. Thank you to all of our speakers tonight, Andrea, Dr. Stoffel, and also Sarah. And also thank you to all of you for participating in the chat, sharing your stories, sharing a little bit about your background. I will be going through the chat and also going through the Q&A and moderating this session. And also, we had some people submit questions beforehand. And so I'll start with a question from someone who registered, and then I'll look through the others and we'll go from there. So that being said, one of the questions that reoccurringly came up, given that Thanksgiving is around the corner, is how do we facilitate some of these conversations with family members? And maybe Andrea, you can jump in and answer some of the question here, but really, like, how do we bring up genetic testing, talking about our family history, thinking about should all family members go together to get tested, or, who would be the best person to test?
Yeah, great question. And I think really timely. So whoever sent that in, great thoughts thinking about family being together and trying to start having these discussions. We do often recommend that to people we see is when you've got your family together, start having these discussions. With each family, it can be a little bit different. Some families are more willing to talk about health with each other, others aren't. We tend to encourage people to take the focus of, just saying, information can be helpful in screening. And so it would be good for us to know if there's things that run in our family so that we can do more screening to stay healthy for longer. That's kind of the goals for all of us, right? We all want to stay as healthy for as long as we can. I would certainly say when thinking about doing genetic testing, if ever possible, it's always most informative to start with somebody in the family who has been diagnosed with cancer. Now, that's not always going to be possible. So if that's not possible, say it was a parent who was diagnosed with cancer and they've passed, then all of their children and siblings should generally consider doing genetic testing, because if one sibling does testing and is negative. That doesn't mean that there's nothing in the family. It may just mean that that person does not have cancer is negative. So certainly thinking about all first degree relatives of the person with cancer, if the person with cancer is not able to undergo genetic testing, or if they did genetic testing, but it was a really long time ago.
Thank you. Thank you. That's very helpful. I think something I'm even thinking about going into my own Thanksgiving. And while we're on the topic of genetic testing, there were also some questions submitted about logistics. So I was wondering if, Andrea, you could talk a little bit more. You kind of started talking about it during the presentation, but maybe tell us a little bit more about, is there telehealth available? I know I saw someone from like Rochester in the chat and different parts of Michigan. Are there other institutions with genetic counselors? And also, what are some of the insurance evolutions over time that have happened and considerations there?
Yeah. So one, yes, telehealth is absolutely available, not just at Michigan Medicine, but at other places across Michigan. So if you have care already at a health institution that is not us and you would like to keep it there, there's a good chance that there are genetic counselors there. So and that they offer telehealth. Us at Michigan Medicine, we actually do both in-person and virtual visits. Some people prefer in-person, and we are still available for those, but we do them both ways. As I mentioned, we don't technically require referrals. Now, some people's insurance require a referral. So then in those cases, you'll need your primary care to do so. Logistically speaking, it's not that a primary care cannot order genetic testing. It's just most often that they've expressed that that's not their wheelhouse. They're not really even sure what test to order, and they'd rather you come talk to us to make sure that the correct test is ordered. Other institutions in the state of Michigan are Henry Ford, Corewell, Trinity. So there's lots of other institutions in the state of Michigan where genetics is available. I just saw somebody throw in the chat that they live in Ohio. We can do telehealth, but unfortunately, due to state licensure laws, you have to be in the state of Michigan for telehealth. Sometimes that means we've seen people drive over the border and sit in their car at a park and ride, and that counts, which is crazy, but that's just licensure laws and there's no getting around it. To your question about insurance coverage, this is a little bit of a challenging one to give you a definitive answer on. I can tell you that most insurance is covering genetic testing. Now, does that mean that you have no out-of-pocket costs? Not necessarily. I will say that the labs that we work with at Michigan Medicine, which is a lab that many of the other places do as well, they all have incredibly generous patient assistance programs. Their general kind of approach to doing genetic testing is they do perform a benefits investigation and reach out if your testing is expected to be more than a certain amount. But their self-pay price that they offer for people nowadays, if you don't even go through insurance, is $249, which makes the cost more accessible to some, still a high cost for a lot of people. But generally speaking, we kind of touch on insurance coverage during these visits to make sure that people are kind of informed before, so they don't end up with an enormous bill.
Thank you for sharing that information as well. I think that's helpful considerations. And I'm also happy before this call ends, we can paste some of the resources in the chat. I know there's like a link to find a genetic counselor near me. So I can try and post that in the chat while we're answering some other questions. But another thing I've seen kind of come in through the chat a little bit during the talk and also beforehand is in regards to imaging surveillance. And, you mentioned the endoscopic ultrasound, the MRI, and the CT scan has also been mentioned in the chat. I was wondering if Dr. Stoffel, you could talk a little bit more about what are some factors that a provider might consider in deciding between which type of imaging is the best option for each individual.
So that's a great question. And I think that this is why I wanted to emphasize that it's really important when you're having pancreatic cancer screening to try to have it done through a center that actually has the multidisciplinary expertise to do this. Because honestly, most people who have an MRI are going to have cysts that are found on the MRI, and most of these little cysts are small. They don't have any worrisome features, and we just watch them. It's when cysts start to change over time, or if they develop certain high-risk features, which you kind of have to be familiar with, to know whether whether this is a cyst that we want to intervene on early versus just watch. And I think that in our program, it's actually not uncommon for us to say, start with an MRI. And if there's a cyst that looks a little bit suspicious to us that we can't really figure out, we might do an endoscopic ultrasound before that 1 year time interval to try to look at that cyst in more detail, and sometimes to try to sample the cyst, because sometimes by looking at the composition of the fluid in the cyst, we can look at certain tumor markers to identify whether this is a more worrisome or less worrisome cyst. So this is a very dynamic process. It's very different from just, our usual process of, say, ordering a chest x-ray and getting a radiologist read back. This is actually having multiple eyes on the imaging study. So the MRI is being looked at by the radiologist. It's being looked at by the advanced endoscopist. It's looking at in a multidisciplinary meeting to basically say, is there anything here that we're suspicious of? And I think that to answer your question about why are we alternating imaging between the MRI and the endoscopic ultrasound, a few years back, actually, I think that was about almost 17 years ago, the Johns Hopkins sponsored a study called CAPS-3, where we actually did a CT scan, an MRI, and an endoscopic ultrasound on all patients within 24 hours. And that's where we could actually compare head to head how the tests performed in the same individual in that same time period. And that's where it became very clear that most CT scans don't find things that are visible on endoscopic ultrasound or on MRI. And likewise, there are some things that are seen better on MRI and some that are seen better on endoscopic ultrasound. So through meetings that have involved literally hundreds of experts from around the world, over time, everyone has coalesced around the fact that MRI alternating with endoscopic ultrasound is the best option that we have at this time. And there's a lot of work going on with these research groups trying to see whether AI may be applied that can integrate some of the images from endoscopic ultrasound and MRI that can do a better job at finding things that may not be visible to most radiologists. So I think that there's a real advantage to having your pancreatic cancer screening done at a center that is doing all of this extra. And that's one of the reasons why we always encourage our patients to have their imaging done with us, is because we can't rely on the imaging technologies at other sites that may not match what we do.
Thank you for sharing that. And I think that's really helpful knowledge, and kind of building on this theme of surveillance beyond imaging. A question I see in the chat or in the Q&A portion, and also beforehand, and something I hear from patients is often, how can I do more? And so I think you touched on, biomarker testing, hemoglobin A1C. Something else I hear a lot of buzz in the media about is those UK breath tests or other commercialized blood tests. And I was wondering if you have any advice on, when you see these things in the media, should you contact studies like PROCEED and CAPS-5 and see if there's any information there? Is there clinical trials elsewhere? Should you ask your doctor? What do you do when you see something in the media?
That's a great question. That's a great question. So we take care of literally hundreds of families that are having pancreatic cancer screening. And we get this question a lot, like, oh, I heard about this blood test. Should I be doing this? And to be honest with you, right now, there are two different types of blood tests out there. One is the pan-cancer early detection test that is looking for circulating tumor DNA for many different cancer types. Those tests are usually not covered by insurance, and there is furthermore some concern that those tests may yield more false positives than true positives. And so for people who meet criteria for pancreatic cancer screening, we're already looking at your pancreas with imaging. And if something came back on one of those blood tests that pointed to your pancreas, there really isn't anything more we can do other than look at your pancreas. And if there's nothing suspicious there, we're not going to be able to act on it. So, and then likewise, there's another test that just came on the market that is not covered by insurance. That is a biomarker test, blood test for pancreatic cancer screening. And that test is, the indication for that is people who meet high risk criteria for pancreatic cancer screening. And again, we are also already imaging your pancreas with these imaging studies. So if something came back as a marker on that, there isn't anything differently we would do at this time. I think that as part of research studies, we are, of course, looking to see whether this information could get integrated into the care model. But I think at this point, the answer is we really wouldn't do anything differently with that if we're already doing the imaging.
And yeah, I think that's really helpful knowledge. I feel like I'm hearing so often, what more can I do? And it's really great that everyone wants to be so proactive about their health. So it's important to have these outlets to go to. And again, while we're on this topic, I see one question in the chat specifically about the CA 19-9. I was wondering if you could address some of it. I know there's some pros, some limitations, if you could kind of address those.
So CA 19-9 is a marker that's been around for decades, and CA 19-9 is elevated in some patients with pancreatic cancer. It can be normal in some patients with pancreatic cancer, and it can be elevated in people who don't have pancreatic cancer. So we were participating with Johns Hopkins in a study that was looking at are there genetic factors that affect how people metabolize or how they make CA 19-9? And can we use that genetic information to try to calibrate whether a normal CA 19-9 for one person is actually high for somebody else? And so, you know, Sarah was involved in collecting samples from many of our patients for those genetic studies. And the hope is that CA 19-9 may get integrated into some of these other biomarker tests, but right now it's not good enough as a standalone test.
Thank you. That is very helpful knowledge as well. And for a lot of these clinical trials, maybe Sarah, this is a question for you. Are there any eligibility criteria in particular that individuals need to meet, even if they're not high risk? To NCCN guidelines, for example, they only have one relative with pancreatic cancer and they're negative for genetic testing. Could they still join a trial and make sure, out of being proactive for their care, is there opportunity there?
Well, specifically for CAPS and pre-seed, just having one individual relative affected with pancreatic cancer that could meet criteria, but really we're looking for the criteria for the patient to be considered high risk to undergo annual screening through the MRI and the endoscopic ultrasound. So when patients find us online, they find us through various resources. When they ask this question, I then refer them to either the genetics clinic if they've never had genetic testing, or the GI clinic to discuss with a professional like Dr. Stoffel to see if they would meet criteria for screening due to age or other family cancer risks. And I don't know if Dr. Stoffel can expand upon that for what meets that criteria. But I mean, for CAPS and pre-seed, there are different cohorts. For pre-seed in particular, we have 6 different cohorts depending on the family history and or genetic mutation. But really, we are looking to enroll the patients who are high risk to meet criteria for annual screening for these 2 particular studies.
Yeah, thanks, Sarah. I also wanted to jump in there as to why we don't recommend pancreatic cancer screening for people who don't meet those high risk criteria, and the reality is that there are some data out there to suggest that if we screen people who are not high risk, we have a higher likelihood of finding something that may end up being a false positive, that may end up leading us down the path for more invasive and potentially harmful care. So much like, we always say we need to have a proven benefit to know that it's worth screening. And at this time, because pancreatic cysts are common, and they're found in a lot of people who are even not high risk, we have policies by which we follow some of those cysts for people who are not high risk very differently for how we follow the cysts for people who are high risk. And so the U.S. Preventive Services Task Force really said no pancreatic cancer screening unless you meet high risk guidelines. And right now those high risk guidelines are what most people have come around to rely on.
Thank you for sharing that as well. And I also think, through Sky Foundation and some of the community resources, sometimes contacting them can even be a good liaison or start to kind of guide you to the experts as well. So I'll say that real quickly about Sky Foundation, but sort of jumping gears back to Andrea and the world of genetics. There's a question in the Q&A about sequencing DNA of the tumor. And I was wondering if you could talk a little bit about how that tumor DNA might be different from the DNA we're born with. And in particular, I guess my question's a little bit twofold here, but this particular Q&A question revolves around the KRAS gene. So maybe talking a little bit about that, and then also the twofold part of it would be if there's any clinical trials specifically for somatic or mutation specifically to the tumor. I don't know if the best place to go to would be the clinicaltrials.gov and kind of searching that, or if you guys know of any specifics.
Yeah, this might be all of us kind of jumping in on this one,
Yeah.
but I'm happy to start. So there are in the world of cancer two different types of genetic testing. So there is the germline testing, which is what I was primarily talking about, those genetic variations that were there from the second the egg and the sperm came together. So they're there from the moment you're born to the moment you pass. We don't get to change them. We don't get to pick them. Those are genetic changes that are passed on from generation to generation and would be ones associated with those genetic conditions that we talked about, the BRCA genes, the Lynch syndrome. The tumor testing can be called lots of different things. It can be called tumor sequencing. It can be called somatic testing. Sometimes people do call it biomarker testing. So it takes on a lot of different names. But what that genetic testing is doing is it's looking for genetic changes that are present only in your cancer or only in your tumor. Cancer has genetic changes. That's why it's cancer and not our typical cells, right? It's not behaving the way we would expect it to because it has these genetic mutations in it. Those genetic changes that are present in your tumor are typically ones that are only in your tumor. They cannot be passed on from generation to generation. The primary place where that genetic testing is incredibly useful is in thinking about targeted therapies to treat people for their cancer. So it wouldn't inform risk for family members because those changes aren't passed on, but could really impact treatment decisions. I might let this go over to Dr. Stoffel in a second, but that KRAS variant that I think was mentioned, KRAS is a very commonly mutated gene somatically, so not one that we see generally being hereditary or passed on. But let me pass to you.
Yep, thanks, Andrea. And just to jump in there, sometimes when there's tumor testing done of a tumor and say they find a BRCA mutation, then sometimes they recommend that someone have germline genetic testing to make sure that this isn't one of those inherited mutations that could have implications for other family members. But in general, when we do testing of the tumor and we find, say, a KRAS mutation, that KRAS mutation is almost always just unique to the tumor. And I think that there are a lot of clinical trials right now that are looking at new medications that are RAS inhibitors for pancreatic cancer treatment. And likewise, as Andrea mentioned, for BRCA mutated tumors, there's a specific chemotherapy regimen for BRCA mutated tumors as well. So, but these are great questions and we really recommend that patients with pancreatic cancer talk to their oncologist if they have questions about specific clinical trials that are targeting particular gene changes in the tumor.
Thank you. And I'm hoping to sneak in a few last questions here. So one of those questions I see in the chat is referencing von Hippel-Lindau. And I believe that increases the risk for a different type of pancreatic cancer, specifically pancreatic neuroendocrine tumors. But I was wondering if you could talk a little bit about any potential screening and if they meet any criteria for the studies like CAPS-5 or PROCEED as well.
Yep, so excellent question. And I think we did not include von Hippel-Lindau in the pancreatic cancer screening because we were focusing on screening for pancreatic adenocarcinoma, and certainly von Hippel-Lindau does have a higher risk for pancreatic neuroendocrine tumors. And pancreatic cysts are also very, very common in von Hippel-Lindau, as are tumors of other organs, especially kidney cancers. So there are particular screening algorithms for patients with von Hippel-Lindau, and a lot of the imaging is trying to kind of capture lots of things at once. So maybe not necessarily the MRCP focusing on the pancreas, but actually doing abdominal MRIs that look at the kidneys as well, so that you try to get a wider angle shot, so to speak.
Thank you for answering that. And just in the kind of interest of time, I see one other question that gets to the point I'm hoping to leave everyone with about the world of medicine is evolving. It's good to get involved in research and be proactive if you're interested in, and also just contacting providers and always asking them questions and advocating for yourself is really important. But on that note, I see a question from an individual who has many family members who have been affected by pancreatic cancer, and it seems like they've had negative genetic testing. And so they're asking, how is this possible? Is there stuff we're still looking into, we're still learning about? Anyone welcome to answer this question?
So that's a great question, because I think it's important to note that of families that have 3 or more relatives with pancreatic cancer, we only find a genetic explanation in about 1 out of every 10 families. So most families out there who have familial pancreas cancer, we don't know particularly what's causing it. We don't know if there's a genetic factor that we're unable to detect, or whether it might be something else, some type of environmental exposure or other shared risk factor. So I think it's a really good question, and certainly we are looking. There have been a lot of studies that have done very extensive DNA sequencing in these families, and nothing really has turned up to explain most cases, but we are still looking. And I think that what we know is that in families where there's multiple affected relatives, these individuals do meet criteria for pancreatic cancer screening. But I guess the good news is that the likelihood of developing a pancreas cancer seems to be a bit lower compared to some of the other families that have the genetic changes. So even in European countries, they're starting to say, well, maybe we're only going to screen the people with the gene changes and not screen the people who only have family history. In the US, we're still screening people who have a family history of multiple affected relatives, but I think the data coming from Europe to show that the risk might be lower for these folks is heartening.
Thank you for answering that so much. And in the interest of time, I'll pass it back to Annie, but I'm also going to paste in the chat some of the contact information for the Michigan Medicine Cancer Genetics Clinic, the National Society of Genetic Counselors, who has a link to find genetic counselors in states outside of Michigan. I'll also post the link to the clinical trials we discussed, as well as Sky Foundation. So you guys can all look in the chat for that. But thank you so much for everyone's participation.
Yeah, I'd like to echo that. Thank you so much to all of our speakers, to Sammy for putting this together, and for all of you for being here, for showing up, for paying attention, and for advocating for your own health and the health of your loved ones. We hope you leave tonight with more knowledge, more confidence, and a clearer understanding of how genetics, risk factors, and research all to come together in the fight against pancreatic cancer. Have a wonderful evening, and we hope to talk to you soon.